What are the symptoms of basal thumb joint arthritis?
So basal joint arthritis usually starts with a very vague, dull pain at the base of the thumb. Most of the times, patients don't even know what's causing it. In fact, many times they'll go to a primary care doctor, and unless the symptoms are really very focused on that area, it's hard to elucidate. So I think that it starts with pain with pinch, oftentimes leading to weakness, which then becomes functionally disabling. And I think that's the problem when patients come to see us. It's not just the pain, it's the fact that they can't turn the key to the car or they can't pick up a dinner plate without pain. And then once it interferes with hobbies such as tennis or golf, then they come running in. So it is really a common problem. It's not talked about much in popular media amongst the public. So I think that's one of the challenges we have is just educating people that there is something called arthritis at the base of the thumb.
What is the main difference between joint replacement and the LRTI procedure?
So the difference between joint replacement and LRTI is just implicit upon the fact that you are preserving the trapezium. So that preserves the height of the thumb. I think it's very natural for patients to shy away from the concept of, oh, someone is taking out a bone in my wrist at the base of my thumb. We are preserving that. We're doing minimal even modification to it. And that I think that's a big difference is that you burn no bridges. Once you've done an LRTI, which stands for ligament reconstruction tendon interposition, why do you reconstruct the ligaments? Well, you remove this entire stabilizing bone called the trapezium. Tendon interposition, because the body kind of abhors a vacuum. So you are filling that space with something which is really inert, dead tendon, and you are of course taking that tendon through sometimes some significant incisions, a tendon that is important for power of the wrist. So it's just a completely different concept where you're making a small incision, you're removing just the arthritic portion at the base of the metacarpal, and you're putting the implant into just a shelled out trapezium, as opposed to completely removing the trapezium, using a tendon to then stabilize it, right? That's the ligament reconstruction, and then using the balance of the tendon to interpose. That is a very unnatural process when you think about it. And the worst part is there is no good bailout. If that patient, unfortunately, most patients do fairly well, but when those patients don't do well, there is just not a great solution to revise that.
What is your experience with thumb joint replacement?
So I've been doing CMC replacement surgery pretty much since I've been in practice. I realized early on that I've always been one to try to preserve anatomy. So as soon as I finished my fellowship in Pittsburgh, I started doing a total joint replacement, but I didn't like it because it required cement, and because there's such small bones, particularly the trapezium, to put the cup, which is analogous right to the cup or the acetabulum in the hip prosthesis. But there's a lot of bone in the pelvis. That's a strong bone compared to the trapezium, which is a very small bone here. And I was never very keen on that because the cement has its own issues. So probably that's been almost 30 years I was doing that. Probably one of the few American surgeons who really was even doing prosthetic replacement base of thumb. Uh, that prosthesis was slightly, gradually phased out. But around that time, I had already seen the BioPro implant. What I liked about it was the fact that it was press fit, which is unusual compared to, say, implants in Europe where they have a lot of press fit. Uh, and it was also a modular, meaning you could change the size of the head and the size of the stem, and then it fit into the trapezium. And if you look at, say, the Austin Moore hip, that was a very successful surgery for the hip that didn't require both a cup and a stem. And because we're not walking on our hands, I mean, except for my Cirque du Soleil patients, we pretty much are not stressing the thumb to that degree. So I think it's really a perfect solution.
How do you set expectations for your patients prior to surgery?
So the expectations for patients has had an evolution. These patients did so well that I was very cavalier at first about letting them do a lot. And I realized that, let's face it, even though the technical part of the surgery, the joint is very straightforward, there is surrounding soft tissues, and those tissues, particularly the capsule, are tender for a period of time. So what I've done gradually over the last year or two is really try to minimize their activity for the first month. Not because I was worried about implant failure, but because I didn't want them to have a sort of pain cycle, a vicious cycle starting where they're doing too much. So right now I let them use a removable splint, just hand-based, not up to the forearm, that's not disabling for activities of daily living, but allows the joint to rest. They can remove it for very light activity, but the moment they're going to do something a little heavier, including driving, I say just put this on as a little protection. And I think the rapidity of recovery is much better. No question that the long-term results, no matter how you do this, are pretty good. But what I like about this operation is that the patients recover so much faster. So I don't want to push it. There's no need for them to be, doing all activity within 7 to 10 days. If they do that within 30 days, I think they're equally happy.
Who are good candidates for thumb joint replacement?
So candidates for joint replacement versus LRTI is actually quite easy in my hands. If there is advanced STT arthritis, meaning scapho, trapezial, trapezoidal, right? Many times that means the entire pan-trapezial area is arthritic. And unfortunately, in many of those cases, bone has to go, because you can maybe do a replacement to the basal joint, you can do a replacement or some modification in the STT, but at that point, it's probably more prudent to just remove the arthritic trapezium. However, many patients have very subtle changes in the STT joint, and they're not symptomatic. So when I examine a patient and I press on the STT, if they're not very tender there, I don't put a lot of stock in that. But if they're very painful with a grind test, then I think the bulk of the pain is coming from the basal joint, and I think they're excellent candidates for an implant. So it's really what I call the pancake trapezium, that collapsed trapezium that will not support an implant, where there is pantrapezial arthrosis all around the trapezium. Those patients need to be removed. Now, I will tell you, I only do 2 or 3 a year. The vast majority of patients have arthritis limited to the trapezial metacarpal joint or the basal joint.